I think that when we talk about Medicare reform, we're going to hear some of the opportunities to really do Medicare reform and how we should really appropriately do it. If you think of the challenge that we face in the Medicare program, half of the patients in the program are being treated for 5 or more chronic health care conditions that account for about 80% of total spending. And in fact, virtually all the growth in spending in Medicare over the last 20 years is among patients with multiple chronic health care conditions. And the challenge that we face is that obviously we have 2 distinct programs in Medicare. We have the original Medicare program, which has about 72% of beneficiaries in it, that has no care coordination really that's comprehensive to speak of in it. And we have the Medicare Advantage program, where there's existing best practice models in Medicare Advantage that are very effective at managing chronic disease and saving money and improving quality. We're going to hear some about that today from a very impressive model that has generated and produced really impressive results in terms of both quality and costs.
Medicare patients with multiple chronic conditions see an average of 11 different doctors. And if you can imagine those different doctors sometimes treating the same chronic conditions, but also prescribing medications, some that counteract with each other. But again, it leads to very poorly managed care or no managed care at all, and redundancy in the system, which drive up healthcare dollars. And ultimately is bad for everybody, the members as well as the system. So if I think about the partnership's goals and CareMore's goals, we're very much aligned. CareMore, and again, I'm going to read parts of this, CareMore's mission is to provide a focused, proactive, and innovative healthcare approach to counter the complex problems of the healthcare system in dealing with those that are frail. We serve our members, caregivers, and families, and I want to stress that it's not just our members. We actively involve the caregivers and families in what's going on with the members, what's going on with their healthcare decisions. We help support them and educate them and give them access to the services that we provide. And the whole goal is to help prolong their lives in an active and productive manner.
I came to CareMore after being a primary care provider for both Medicare and Medicaid populations, usually in underserved areas. So I was in the midst of what true disjointed care is about. When we say delivery of health care today is a mess, it has turned into what I call the fast food drive-through window of health care. You're in for 2 hours, but you see your provider for less than 7 minutes. They take longer to make your coffee at Starbucks than you might get in your care with your provider. So when I had the opportunity to talk to the folks at CareMore and really see what this plan provided to the community, to its members, to the providers itself, I said, this is what I was looking for as a healthcare provider. What we find is we work in the triangle as a tripod, essentially, with the member or the patient. We call our patients members because they are both a member of our product and our patient. And we dovetail in with the primary care provider. We do not take over the care of their primary care provider. We supplement and really tightly control those areas of chronic disease that so many Medicare members have.
For the past 30 years in this country and really around the world, in Europe, Canada, Australia, there's been a growing movement of community-based model of self-management. Education and support is provided in community centers, in churches, in senior centers, in senior housing. Can be provided by a trained layperson, a person who has lived with that same chronic condition as you. It's focused on problem solving and self-confidence. What we know from studying people with chronic conditions is that this is a key trigger for getting people activated and engaged in their health. If they feel they can make a difference, they have a sense of self-efficacy, they are more likely to be take steps to manage their health. The skills, interestingly, are very different, very focused on patient-identified problems. You know, it's interesting, when you go to a self-management class in the community taught by lay leaders, people will come up with goals like, well, I want to go to my daughter's wedding. That's the goal. Or I want to be able to go, frankly, to get the mail, walk down to the mailbox and back. That's a goal that motivates people, that gets people activated. It may not be a treatment goal from the clinical side, but it's a goal that motivates folks to take action. And self-efficacy is the main goal. So this idea that, you know, who's responsible? Well, it's really both, isn't it? It's the integration of these opportunities in the community with the traditional health system, medical, the kinds of things that CareMore does are exceptionally, they're very valuable, very important, but they need to be augmented as well.